So Steve has just given you a lot about the theory of what's going on elsewhere in the country. Caroline is actually going to put it into context as to how to do it, how to get there, how to achieve the means, the end result. Caroline has been in the Newport Pagnell Medical Centre for 6.5 years now, a practice which was awarded outstanding in CQC under Caroline's management. So that in itself is well worth noting. When you read the practice's visions and aims, you really can't help but have respect for Caroline and the work she's done. So I'm very delighted to welcome you, Caroline.
Hi, thank you. It's great to be here with Steve, who's our primary care supporter and has really helped us move forward. So, I don't know about you, but last year it felt like we were running a marathon, and our theme for our practice last year was how to keep going when you're running a marathon, how to pace the long run. And there were times when individually all of us felt like, you know what, I think I'm just going to give up. But we thought about it and in the end just tried harder. And I think the important thing about marathons, as we have been in one, is that actually it's not just about one person on their own. That the way we survive a marathon is, in a sense, by helping each other, or here, by passing the baton. So that's what we did, and this year our theme will be something much more positive, and I love the theming for today. I think it's brilliant. So the first question we had to ask ourselves, and we've been doing this for about 6 years, but basically, where are we going? And we've kind of, every year the partners think about where are we going, and then the teams do their bit as well. So each team also thinks about it. This year, in fact, on Saturday, the partners now going away for the day, and we're looking at scenario planning. I don't know if anybody's ever used it, but what it does is think about, okay, so what are the top drivers of external drivers to us for change, and how are we going to have a strategy that helps us meet those drivers? Because the world is changing that we're working in, and if we don't know where we're going, how are we going to get there? So we'll see how it goes. It'll be interesting. But from that, then we need to think about, okay, so this is where we want to get to, and this is what might happen. So what's our plan to get there? And our plan from last year, and I think it'll change this year, we've had our final retirement. We had a retirement every year for the last few years, is to embed a strong partnership. I think when anybody leaves, you've got a new team, and you need to build that team. To maintain morale, training is absolutely key, because we try and give high quality care. How we're going to expand and consolidate that, because that's part of our plan to maintain stability for the practice. Clinical quality, and maintaining the financial stability of the practice, which, as we all know, is really hard at the moment. So every year we have a conference. We employ about 110 people, so half of our business is primary care and the other half is provider services for the city. And every team comes up with their own strategic plan for what they want to achieve. This is not the CCG saying you've got to. I don't know why they think they need to do that. We're quite able to see what we need to do. And for instance, the practice nurses last year wanted to look at hypertension because they felt that they could improve their management of hypertension. And in fact, I know, because we've just come to the end of the financial year, that they have succeeded in doing that, and they will be presenting that at this year's conference. We are a bit different. We've always made use of what we call first mover advantage. So anything that comes up, we're in there first, because normally there's a little bit more money in it when you go in first. And we're a PMS Plus practice. So we were lucky enough to be able to form an integrated team in 1999. We managed them, and they were lent to us by our community provider. And then we 2P'd them across in 2006. So we have a huge employment risk, but it really helps us in the way that we work. And you can see there, the lighter blue are kind of slightly later people to join our team. But it's demanding, but it works really well. This is our it's not the best quality, but this is our A&E attendances by age. And the red line that you can see at the bottom there is our over 75s admission rate to secondary care. The two peaks are Easter and Christmas. And I was really pleased with that. And that, I think, shows how working holistically is successful. Our community matron is a very old-fashioned model in a way, and we'll do anything that it takes. So like for some people, we had an older lady who was being admitted every bank holiday. And when we talked to her, we realised that her family went away every bank holiday, and that actually if our district nursing team just literally knocked on the door and said hello, she stopped being admitted. They've helped an elderly gentleman whose house was a complete tip and it was just unsafe for him to be there. With local voluntary services, sort that out and he's still at home. So it's not always high-level clinical stuff that's needed. It's really holistic care. So another thing that we've done is called the multidisciplinary team around the doctor. It's quite hard, I don't know what it's like in your area, but it's quite hard for us to recruit doctors. So what we've done, because they're under immense pressure, is try to really see how we can support them with every area that we can, so that they're only doing what only they can do. And so going from that, which I know a lot of people feel, to that. So right person first time, so that when a patient rings in onto our phone list in the morning, if it's an admin request, they don't talk to a doctor. Our MedSec team will talk to them or whoever, somebody, the right person. So about signposting patients to other clinicians or administrators rather than to doctors, unless they need a doctor. We have created something which I call the GPPA, which is really a receptionist, but it's one who works slightly differently. So we have a GPPA shift every day. And what they do is work much more closely with the doctors and talk to patients in a different way. So they'll ring up and say, I'm Dr. Smith's personal assistant, he's asked me to phone you, and da-da-da. And they get a different response, which is quite interesting. Our doctors would like one each. But we really can't afford it at the moment. I'd love to give them one each. So admin support for doctors, as I mentioned, from the MedSec team and the data quality team, who are dealing with all the notes coming in and trying to make sure that doctors have good information to base their diagnosis and their care on. We've got a paramedic who does visits to try and reduce that strain on GPs, and he works very closely with our GPs. And then minor illness nurses to support the duty doctor, and a pharmacist, which she's just started, clinical pharmacist. And we have a vision for moving forward. We've just employed another minor illness nurse so that we'll have an on-the-day team, which hopefully will help the demand. And this is what I absolutely believe, that every person, and I mean every person in our organisations, is important. And we talk about leadership from everybody, and that's really key, because actually everybody has some good ideas, and if we don't value it, well, they'll probably leave apart from anything else, but we won't actually really understand the whole picture, and that's so important. So, primary care home. I'm going to tell you a story. About 2 years ago, I was asked to see a widow of a patient who died recently, and I met with her. And she told me this I can still see the story, do you know what I mean? She explained it so well, I could see it. A story about her husband who'd come to see the doctor. It wasn't the doctor's fault in any way at all. He came to see the doctor, but actually never got the courage to say what he needed to say. He was actually severely depressed, but very good at putting a mask on it, and we all know patients like that. And then she told me about how she'd pieced together, he died not that long after, she'd pieced together his last few days. And they'd even found the CCTV footage of him buying rope in a shop. And then she told me about the police report who'd found him, he'd hung himself in a local forest. And at the time, my heart went out to her, and I just wanted her to really know she'd been heard. But I never thought further than that. And I think the thing for me that's most exciting about primary care home is actually finding out what our population need from a health perspective. And when I say that to non-clinical people, I feel really embarrassed because they think that's what we do all the time. But Steve's picture of the telescope is absolutely it, because we're dealing, in our surgery anyway, with what's turning up. So we went to the local population health leads in our council, but we also talked to lots of other people, talked to our counsellor, our voluntary organisations, all kinds of people. And this is basically what we found, which you can read for yourselves. The really surprising thing for me was the mental health needs. And we're in a relatively affluent area, quite a lot of country villages, and I hadn't known that was so. I really hadn't known. And I was a nurse in this area before I did my MBA and everything, so I really just didn't know. So our vision is to build on what we're lucky enough to have already, and I do know that we're lucky enough to have it. I think with some of the STP plans, they're looking at, could we work differently with our district nurses, for instance? And, you know, if that's a possibility here, I do not know, but I think it definitely works. It's a very different working relationship. And talking to Steve helped us understand that we needed to target our care to each segment of our population. So, I mean, it's been printed in the brochure this bit, but these are the 3 groups we came up with. And when I met with the counsellor for Newport Pagnell, as opposed to Milton Keynes, who also works in our youth club, I was just shocked to hear what she was telling me. And she told me she thought 1 in every 2 11-year-olds to 18-year-olds had some kind of a mental health need. I was just amazed by that. And when she went on to explain what that meant, yes, there were sort of complex and enduring problems, but also it was things like sexting, Facebook bullying, sexual identification, young men taking their lives before they got to 18. And I was really shocked by it, actually. And then we looked at our working age population, and we were thinking we were probably going to be looking at long-term conditions. We've done quite a lot of work on that. And then when we actually asked the question and looked at it, we realised we need to do mental health needs again. And then our frail elderly population. And for each of those, and this is really important, we've actually only got 2 columns, but I'm thinking the 3rd column makes sense because I'm quite often thinking which column should I put these in. From Steve's chart I'm talking. So first of all, currently well, but with less complex needs. And this for us is wellness, not illness. And we've talked a lot, haven't we, in the NHS, that we need to change the way we deliver care because we need to get people to take responsibility for their health. And boy, is that a difficult thing to do. And we've never yet succeeded. But that's one of our focuses, if you like, for each of our 3 groups. And we're right at the beginning, but it's quite exciting, I think. And then those who are struggling with many layers of need and need that integrated team wrapped around them. So young people aged 11 and over, what are we doing? Working with lots of voluntary organisations. So Compass is a drug and alcohol support service. Places for People is a local gym. And we talk to them, and they're going to put on special classes, and I'm not really into gyms, so, things that they're going to do that the young people really want to have, to try and bring them in and not feel isolated. So if they're in a group where they're valued, that will help them at school when maybe they don't feel valued. And that's People for Leisure that I've just talked to you about. And also with our local school, the CCG and CAMS. What's quite exciting about primary care at home is the bit I love, but talking to someone at lunchtime, they weren't so sure, but is just talking to people who give care or who are involved in some way around our community and saying, let's meet, let's see what we can do together. And you know what? Money never is talked about so far. So I think this is a win, but maybe people don't. So, for instance, we're having a mental health therapist come into our practice. We're not charging them for the room, they're not charging us for the therapist, we're meeting the needs of our patients. It seems to me everybody wins. So the next group, IAPT are providing primary prevention and CBT, again in a room if we can manage it. We're on shifts in rooms, but we have just opened a new practice as well. And this is quite an interesting project, working with people with complex health needs to try and they're people who take a lot of time up, a lot of GP time up. And if we can give them care that stops them needing to do that, then we're helping our GP's workload. And we're also helping them and stopping them, we hope, being admitted to secondary care, which they tend to be quite a lot. So we're picking them up by finding out who's been admitted to secondary care and who has the diagnosis that we're looking for, and then providing in-house therapy and support. We're doing mental health training because actually talking to our practice nurses recently, they were, I think, brave enough to say, actually find this quite scary. What are they going to say to people if they open up this can that they don't know how to answer? And they need to understand that actually it's not about answering, it's really about listening. But also they need the support, they need to know what they're doing. We're working with our health visitor team to support postnatal depression in our young mums and dads sometimes. We've got health and nutrition clinics, which are actually going really well. And in the past, when we've tried that kind of thing, it hasn't worked so well. But it's oversubscribed and working well, and some research being done by a dietetics student who heard about what we were doing and was interested. And a single pathway for multiple long-term conditions care, which I have been trying to introduce for about 10 years. It's really hard, but we're getting there now. We want to become primary care navigators and use social prescribing so that, again, it doesn't have to go to the doctor, but patients can get their needs met frail elderly, working with a local club, I suppose you'd call it, that does all kinds of stuff for the elderly. They do Pilates to Tai Chi and things, but they also have day centres for people who need more care. Talking to the hospital again, we've done this work in the past, but trying to grow more, not just avoiding emergency admissions, but actually working before they're discharged. Because we all know an older person wants to get home, and if they're asked what the situation, they'll say it's fine, and then they get home and they're not. We've just got this new clinical pharmacist who's going to be on the day team, but also reviewing complex patients. And focus on end-of-life care other than cancer. That's because we actually our cancer care is working really well, but we realise those with other diagnoses are really maybe not getting the care that we would like them to have. So to finish, I'll just go back to what I believe, which it's about each individual working together and valuing each other. Thank you.
Thank you very much indeed. I'm just going to get Steve and Caroline back on the stage here for questions before we move into the next session. We've tried really hard. Very sorry. If you want to open the door again, try see if that helps. As I said at the beginning, the LMC's got a number of solutions, but one of them isn't to sort the temperature out in this room, I'm afraid. We have tried. Yes, Hayden, fire away. First question.
This is a question for Steve. Who does Dorothy ring, and what are her qualifications?
Yeah, great. So within the model, there is a single point of access for that population. And by single point of access, we mean one point of access, not the 5 single points of access that we are given as GPs. So, and I think you're able to do that when you have a defined population, as I say, about 1,300 across this sort of size population, who are essentially man-marked. You're able to have all those people within their care plan having the number to call, and there will be a call handler who will manage the call and then will assess the need of the person and then direct them to the most appropriate person to manage the reason they're calling about, which could be clinical, might not be. So it's not only a proactive model, it's reactive through one point of access that you would call as a GP or as a practice as well.
So would they be a receptionist or a nurse background?
Well, I think there's 2 steps to the pathway, just like there is in the practice. I think there's a call handling function, which is, I think, a greater skill set than a traditional receptionist. So they'll be able to, either with some sort of IT support or otherwise, be able to actually make an assessment of the reason the person's calling, although they wouldn't be a clinician. And if it's a new clinical matter, they could pass the person through to a clinician. But if it's, say, to find out some information about their wheelchair or about their housing, then it can be passed through to a more suitable person. So there needs a skill set there, yeah, absolutely.
To Cruikshank.
Alistair Cruikshank, GP over in Hitchin. How do you decide in this model how much GP resource to give to each segment of the population? And how do you square that with perhaps practices that are not merged and working to, not working as a single business and perhaps working as separate businesses? How do you get them to give up their GP time to that particular segment of the population?
I would say that we're not asking them to give up GP time. These are patients they'll be seeing already, but actually they're not seeing any extra workload because most of it is being done by other people who are well able to do it, so district nurses, whatever it might be. So in fact it's reducing their workload except for those patients who really do need their input.
Yeah. So it was quite early on when it was sort of the end of last year when I'd started working for the NAPC, and I went to one of our first sites in Thanet in Margate Primary Care Home, and there was a wonderful GP there called Ash who spoke about him working in the rapid response service, which was at the time based in A&E, and he's a local GP, and he was speaking with such enthusiasm about what he was doing. And I said to him, as is often the question, well, either who remunerates you for your time in A&E, or how's the practice remunerated for your time? And he says, well, we don't see it like that. As Caroline says, they are people that they are their patients anyway, and through having a larger team, including a larger number of GPs to work through, the practice is able to release Ash for so many sessions, to spend time seeing frail older people in A&E and preventing them being admitted to hospital, because they get additional benefits from having the resource of other people who can take off some of the GP pressure. So I think it's beginning to think that there's a finite demand and a finite need out there. It's about how we share the resources across the primary care home. And so it's a different way of thinking, but I think why Ash was willing to take time out of the practice to do this work in A&E is because he loved working clinically with frail older people in A&E, where he trained. The practice is able to get more resources to manage their work, their sort of day job. But also I think it's because it's his natural community. It's not a sort of a federation or an SDP that's remote. It is their local community, and they're willing to invest in that. But and he's enjoying it. He's loving doing different things.
Any more questions for Steve and Caroline? Steve, you did say, I think, during the course of your talk there that you are accepting applications for more practices that might be interested, or more groups of practices that might be interested in primary care home. Can you give us some idea about the application process and?
Yeah, so in my last slide there was a link, but if you just go on the National Association of Primary Care Home website, there is an application form there. We've got an event with all our new third wave of primary care homes. It's about 60 odd on Tuesday in London, so it's probably a bit tight to have applications in and accepted by then. However, we are keen to get more primary care homes up and running. So I think if you can't get through on the website, just email me at stephen.leitner@nhs.net, and I'll do my best to help you, because I think it's a good thing, and from what I've seen, it is certainly helping practices to do the things they need to do and want to do. So please do get in touch.
Certainly the message I'm hearing very much is that it relieves practice workload, and today is very much about how do we start to make inroads into exhausted teams and actually carry on delivering care in very good ways. Any final questions? Let's move on. Thank you very much indeed. Oh, sorry.
Presume there's no funding for this, so have you evaluated, when you're obviously an enthusiast, have you critically evaluated it?
Yeah, so there were a couple of evaluations. Again, you can look on the National Association of Primary Care website. So one was done by the Nuffield Trust, and one was done by PA Consulting. And it's quite early days, but we have seen benefit in terms of staff satisfaction, which is an important reason, as we've stressed today, to do this, but also in terms of patient experience and some outcomes in terms of, for example, reduced A&E attendances and reduced admissions, which I think is necessary over time for that resource to ultimately come back to primary care. So it's early days, but from the evaluations that we've seen, it is beginning to have the consequences, the intended consequences that we're looking at. I think, Caroline, you've found the same, that it is beginning to make a difference, particularly in terms of the populations you've been focusing on.
I think it's working with other people in the community who we weren't really working with before. And our paramedic always tells the story of whenever he's ringing up trying to refer a patient, the response he often gets from different organisations is, oh, I think this organisation will be able to help you better, or I think they'll be able to help you better. And people kind of pass it along. And when you're in one team together, that doesn't happen. So that helps.
Brilliant. Thank you both very much indeed.